Right, okay, apologies about the delay since my last video. This one and the next few ones are going to be a little bit different. So I've come across two past papers that cover specifically pharmacology, and I want to run through them. Hopefully these will be a little bit shorter than my previous videos. There are some kind of run-on questions, so to speak. So not all of these videos are going to have exactly 10 questions to them. Might have like 12 or something like that, just so we can finish like that section. But without further ado, let's carry on. So question 51. Mr. IHD is a 65-year-old man. He has a history of ischemic heart disease, which is managed by the following. So we have a few drugs here. So we have verapamil 120 mg, and then we have TDS. So I'll just quickly go through these so you know what it means. So TDS is Latin, because of course it is. Ter di sumendum, I believe it stands for. And that says, well, that means to take 3 times a day. So TDS, 3 times a day. Then have glycerol trinitrate spray, 400 micrograms, which is PRN, which stands for prorenata. And that's, again, just a fancy way of saying take as needed. TDS, 3 times a day. PRN, as and when needed. Then you have aspirin, which is OD, stands for omnidai, which means every day. And then simvastatin, 40 milligrams, which is ON, and that stands for omni nocte, which means every night. So we have 120 milligrams of verapamil 3 times a day, glycerol trinitrate as needed, aspirin once a day, and simvastatin once a night. So all of these doses were confirmed as correct by the pharmacist, and he has no known drug allergies. However, he was admitted to hospital suffering from pulmonary edema secondary to chronic heart failure. His relevant test results are summarized. So full blood count, normal. Thyroid status, normal. Ejection fraction was a little bit less than normal, so we have 38% when normally it's expected to be above 45% for the normal range. The EGFR, so that's the glomerular filtration ratio, is 70 mils, normally expect it higher than 90. And then you have potassium, which is 4 millimoles, normally you expect it between 3.5 to 5, so that is in the normal range. So that's okay, it's just the ejection fraction and the glomerular filtration ratio that's lower than we would expect. On admission to hospital, Mr. IHD is confined to bed. Which one of the following should also be added to his prescription? So the drugs we have is alteplase, clopidogrel, dabigatran, enoxaparin, or warfarin. So the first thing we want to be thinking about with a question like this is, what is he most at risk of? What are we concerned about? And the key part of this is this little section here. So Mr. IHD is confined to bed. And this is very important because being confined to bed is something you should be triggering in your brain. Okay, this person is at risk of a DVT, and that is a deep vein thrombosis. And that's when you get a blood clot that forms in a vein, hence the name, but usually it's in the legs. So deep vein thrombosis. So when you're confined to a bed, as this gentleman is, this is going to lead to a few things. So you can have decreased blood flow, which can lead to something known as venous stasis. It can also increase endothelial injury and cause a hypercoagulable state. So when you're confined to bed, because your movement is restricted, this will lead to a decreased blood flow in the affected region, so in the leg in this case. That prolonged immobility leads to venous stasis, where blood will pool in certain veins in the body. Both of these can cause stagnation, so the blood is in one area and there's an increased risk of a blood clot forming. In addition, because you have that prolonged immobility, it can sometimes cause injury to the endothelium because you always have that pressure on it. And it leads to what's known as this hypercoagulable state, which is basically just another fancy way of saying that the blood in that region is more prone to clotting. So all of those factors are just saying increased risk of clotting. And if you have a blood clot in the leg, okay, that's pretty bad, but it's manageable. The problem is when the blood clot then moves, it can go around the body and go to a vital part. That's when you can get a myocardial infarction, something like a stroke, something like that, something that can really mess you up. So it's something that we need to take good care of so that the patient doesn't involve that. So let's just quickly run through what the drugs are that we have here. So alteplase. So alteplase is a thrombolytic agent, and that's used to dissolve blood clots in conditions such as acute myocardial infarction, and ischemic stroke, stuff like that. So our patient, Mr. IHD, does have a history of ischemic heart disease, but at the moment, at the time in which he's come to see us, he is not experiencing any kind of myocardial infarction. So we would not be using alteplase in this condition. Next we have clopidogrel, which you may have heard people say is a blood thinner. So more specifically, clopidogrel is an antiplatelet medication, and this again is used in patients with a history of ischemic heart disease, and it's used to help prevent further cardiovascular events. However, the reason we wouldn't be giving clopidogrel to this gentleman is because Mr. IHD is already taking aspirin. Aspirin is another antiplatelet agent. In fact, I think you've probably heard whenever someone has some kind of heart problems, or even if someone's at risk, usually they'll say, okay, take some aspirin straight away. So we don't want to be adding clopidogrel on top of this gentleman's drugs, because if we're adding two antiplatelet medications, that's going to then increase the risk of bleeding. We're going to have a double whammy effect, so we don't want to be doing that. And then we have dabigatran and warfarin. So both of these are anticoagulants. So they are something that's used in cardiology quite a bit, but they are not typically used for the prophylaxis of deep vein thrombosis, especially not in hospitalized patients. The reason for this is warfarin requires close monitoring of the international normalized ratio, the INR, and dabigatran is again just not something that we would typically use for DVT prophylaxis. So that gives us our correct answer. So the correct answer is enoxaparin. So much like warfarin and dabigatran, enoxaparin is an anticoagulant medication. However, it's specifically used to help as prophylaxis against deep vein thrombosis. So it's in the same category as these two, but enoxaparin is what you want to be thinking about when someone is confined to a bed and you want to be helping to stop the risk of deep vein thrombosis. Question 52. Following the prescription to manage Mr. IHD's chronic heart failure, which one of the following should be monitored to help inform subsequent dose changes? So is it blood pressure, C-reactive protein, D-dimer levels, internationalized normalized ratio, or plasma concentrations of drugs? So if you want to have a little guess now, I'll give you a second and then we'll go with what the correct answer is. Okay, so the correct answer is blood pressure. And let's kind of talk through why that is. So when you're managing a patient with chronic heart failure, monitoring the blood pressure is absolutely vital because it helps to assess the effectiveness of whatever treatment you're giving them. It's no good just giving them a whole bunch of drugs, but you have no idea what's going on. You want to be constantly monitoring the effects of it. So changes in blood pressure can help indicate how well the heart is functioning and whether the prescribed medication is actually doing what you want it to be doing. There could be so many reasons why that's not the case. So that's why if you go to the doctors, taking your blood pressure is something that we do very routinely just to make sure that everything is going on as it should be. It's a really good way of monitoring what's going on. So the other options we have here, so we have C-reactive protein, and I made sure I've got a little diagram here. So CRP, or C-reactive protein, is a marker we use to check inflammation. So it's not directly related to heart failure management. It can play a role in it, that's why we check it sometimes, but it's not used to assess the efficacy of heart failure treatment, and it's not used to inform medication adjustment. So the higher the CRP level, the more inflammation you're going to have in your body, but it's not very specific. It isn't unique to one specific disease. So it's usually used to help monitor certain inflammatory flare-ups as opposed to diagnose. And next we have D-dimer levels. So D-dimer levels are markers of the blood, and these help to check the level of clot formation and breakdown. So D-dimer levels can be relevant in certain situations, especially if you suspect that the patient has a pulmonary embolism, for instance, and that is something that we want to be checking out because that will kill you. That's a very dangerous one. But again, it's not used to monitor the management of chronic heart failure. So next we have international normalized ratio. So an INR test is something that we use to measure how well the blood clots by assessing the time it takes for the blood to coagulate. So this is typically associated with patients that are on anticoagulant medications such as warfarin. However, it's not directly related to heart failure management or medication adjustments in heart failure, so that would not be the correct answer. And then finally, we have the plasma concentration of drugs. And this can be important with certain medications, especially something like digoxin, which can be toxic if the levels are too high. But again, it's not something that we use to measure heart failure typically. So the correct answer here is blood pressure. Question 53. And from this point onwards, as soon as I finish, I'm just going to keep on talking. So if you do want to pause it, try to be on point with it. I'll leave like a couple of second break, but pause it to have a go at the questions yourself. So Mrs. Rose Tree has developed peptic ulceration, and she is currently taking diclofenac 25 milligrams TDS, so that's 3 times per day. And she has now been prescribed omeprazole 20 milligrams OD, so once per day. Non-steroidal anti-inflammatory drugs are associated with ulceration because of which of the following? So the production of cytoprotective prostanoids are inhibited. There is a compensatory increase in leukotriene synthesis. They are weak acids. They cause local irritation. They cause relaxation of the lower esophageal sphincter. So 1, 2, and 3. So the correct answer to this is the first one. The production of cytoprotective prostanoids is inhibited. So non-steroidal anti-inflammatories, we can see from the diagram here, inhibit the activity of cyclooxygenase, so that's the COX enzyme, and these are responsible for the production of prostaglandins. So prostaglandins are very important in maintaining the integrity of the gastrointestinal mucosa, and they do this by promoting the secretion of both mucus and bicarbonate, and these act as cytoprotective factors. So cytoprotective factors are basically just a way of saying substances that help protect the cells from damage and promote their survival. So in the context of the gastrointestinal tract, cytoprotective factors are substances that protect the cells lining the stomach and intestines from damage caused by other factors such as high levels of stomach acid, bile acids, and other irritants. So the inhibition of prostaglandin synthesis by NSAID, so by non-steroidal anti-inflammatory, reduces the production of these cytoprotective factors, making the gastric mucosa more susceptible to damage by gastric acid, which in turn can lead to peptic ulceration. So we'll quickly run through the other ones. So there is a compensatory increase in leukotriene synthesis. So NSAIDs do not affect leukotriene synthesis at all, and they are completely not involved in the mechanism of NSAID-induced peptic ulceration, so it's not that one. They are weak acids. Technically, yes, non-steroidal anti-inflammatories are weak acids, but this property is not related to their association with ulceration. They cause local irritation, so again, this might be true, but NSAIDs cause that peptic ulceration through their systemic effects on prostaglandin synthesis, not through any local irritation. And then finally, they cause relaxation of the lower esophageal sphincter. So yes, NSAIDs can cause gastrointestinal side effects. So one of the more common ones is GERD, so that's gastroesophageal reflux disease. and that is related to the relaxation of the lower esophageal sphincter, this is not the mechanism that is associated with peptic ulceration. So the correct answer is the production of cytoprotective prostanoids is inhibited. So as you should be aware, omeprazole is what's known as a proton pump inhibitor. So one of the ways it exerts its mechanism of action is by decreasing the level of hydrochloric acid that is produced in the stomach, and without having the hydrochloric acid, which is something that can kill a lot of bacteria and a lot of stuff that we don't want entering the stomach, because that is now reduced to deal with the effects that we're trying to get rid of with omeprazole, while we're trying to deal with that kind of stomach discomfort, it can have a side effect of, well, it essentially is the side effect of reducing these protective factors. Question 54, so carrying on from that, which one of the following is an important property of proton pump inhibitors such as omeprazole? Is it that they cause significant hyperkalemia, they are activated at low pH values, they block an ion channel in the proton pump, they have significant affinity for muscarinic receptors, or that they block beta adrenoreceptors? So let's see, they cause significant hyperkalemia. No, they do not do this. Hyperkalemia is not a known side effect of PPIs, so no. Next, they are activated at low pH values. So this one is actually the correct answer. So PPIs are prodrugs. So that essentially means that they are an inactive or less active compound that after administration into the body is metabolized to its active drug by a metabolic process, usually by enzymatic conversion or some kind of chemical reaction. So PPIs are prodrugs that require an acidic environment for activation. Once absorbed, they accumulate in the acidic canuloculi of the parietal cells in the stomach. So the parietal cells are the ones that produce hydrochloric acid. And here they are activated by that acidic pH. So they form the active sulfonamide derivative. And this covalently and irreversibly inhibits the H+, K+ ATPase proton pump. And this will thereby suppress gastric acid secretions. So then just quickly go through this, because this is one that caught quite a lot of people out. So they block an ion channel in the proton pump, because that's something that we're often taught at medical school, that omeprazole is a proton pump inhibitor. So the logical induction is to think, okay, if it's a proton pump inhibitor, it must block an ion channel on the proton pump. And this statement is not fully correct. So PPIs will inhibit the proton pump, but they don't do this by blocking an ion channel. They do this by irreversibly binding to the pump rather than by blocking the ion channel. And I know some of the other students, some of my friends, and actually me as well, I've definitely made this mistake of assuming that a pump and an ion channel were synonyms of each other, and they're not. They're two very different structures. So make sure you keep that in mind, because some of the questions will try to trick you by wording them in this way. They have significant affinity for muscarinic receptors. Nope, they don't have any significant affinity for muscarinic receptors. In fact, their action is completely unrelated to muscarinic. So don't be thinking of muscarinic when you're hearing about PPIs. And then finally, they block beta adrenoreceptors. Again, same thing. They don't. They just don't. Their mechanism of action is unrelated to beta adrenoreceptors. So the correct answer is they are activated at low pH values. Question 55. Proton pump inhibitors such as omeprazole are commonly associated with a risk to which one of the following? So is it allergy, gastrointestinal infection, hypokalemia, life-threatening drug interactions, or neutropenia? So again, let's just kind of work through this logically. So what do PPIs and what do omeprazole do? Well, the function of them is to reduce the amount of acid produced in the stomach. And as well as digesting food, what is another factor or another use of the acid in your stomach? Well, it's a form of permanent defense in your body. You have acid in your stomach, so if you do ingest bacteria, you do ingest stuff that's not meant to be there, most of the time it's going to be getting killed by the acid. So that's one of the protective factors that the body uses to protect you against infection. So if we want to decrease the amount of gastric acid, we want to decrease the pH in our stomach, what's going to happen? That's going to give us an increased risk of infection. So the correct answer to this would be gastrointestinal infection. And this is something that you need to be looking out for. So in particular, if someone has been prescribed PPI, they are particularly at an increased risk of infection with something known as Clostridium difficile and certain other enteric infections. So the suppression of this gastric acid creates an environment where the stomach is now more hospitable to bacterial overgrowth and colonization. So the risk of gastrointestinal infections therefore increases. So allergy, yes, there is a risk that certain people might have an allergic reaction to proton pump inhibitors, but it's not a common risk factor associated with PPI use. Hypokalemia, again, not a common risk factor. It's not something we generally consider. In very, very rare instances, it might happen, but that's usually as more of a secondary mechanism than as a direct result. Life-threatening drug interactions, again, possible, yes. They can interact with other medications, which could potentially result in altered absorption of metabolism, but these interactions are not typically life-threatening, and it's not something that we would really be thinking about with a PPI. And then finally, neutropenia. So neutropenia is when you have low levels of neutrophils, so low levels of white blood cells. Again, not something we should be thinking about. It's not a common risk associated with PPI. So technically speaking, all of these are possible, but so incredibly rare that it's not something we're going to be thinking about. The most common one we're going to think about is this gastrointestinal infection. Question 56. A 25-year-old man is being treated for ulcerative colitis. His current drug treatment is mesalazine, a 5-amino salicylate tablet, 1.5 grams daily, prednisolone 20 milligrams per rectum, but he reports a sore throat and has poor control of his condition. His sore throat should raise suspicion of which one of the following? So is it adrenal insufficiency, a granulocytosis, an interaction between mesalazine and prednisolone, drug-induced gastroesophageal reflux, or oral candidiasis due to steroids? So let's go through these. Adrenal insufficiency. So this is a potential side effect of long-term systemic corticosteroid therapy, especially with something like prednisolone. However, sore throat is not a symptom we associate with adrenal insufficiency. So if you suspect someone has adrenal insufficiency, some of the things you want to be looking out for is stuff like, fatigue, general weakness in themselves. They might experience weight loss. It's quite a common side effect. They can have a loss of appetite. Sometimes they can feel nauseous when they're trying to eat. Sometimes they'll vomit. Abdominal pain, maybe constipation or diarrhea, low blood pressure. Obviously, you don't have as much adrenaline in your body, so your blood pressure is going to come down. A bit of dizziness, a bit of lightheadedness, especially when you go to stand up. Things like that. Not a sore throat. That's not something we're going to be looking for with adrenal insufficiency. So next we have a granulocytosis, and points to you if you figured out, oh, there's a diagram here of a granulocytosis, so that's probably the correct answer. So a granulocytosis is quite rare, admittedly, but it is a very serious side effect of mesalazine. So a granulocytosis is something that's characterized by a marked decrease in the number of granulocytes. So granulocytes are a type of white blood cells, and they include things like neutrophils, eosinophils, basophils. They are essential for fighting off bacterial and fungal infections. So when a patient is suffering from a granulocytosis, the number of circulating neutrophils, which is the most abundant type of these granulocytes, is severely reduced. And as a result, as you might think, okay, the number of white blood cells in a patient is lower, so they're going to be at a much higher risk of infection. So if a patient is coming in complaining of a sore throat and you know that they have a risk of being susceptible to more severe infections, that's usually kind of a red flag that this could be an early sign of a granulocytosis, as the infection is probably as a result of the lower white blood cell count, so the lower ability for the body to fight off that infection. So it's not the next one. So an interaction between mesalazine and prednisolone. Whilst interactions between them are possible, sore throat is not the kind of side effect you would be thinking of, so wouldn't be that one. Drug-induced gastroesophageal reflux. Again, that's not a known side effect of medication. And usually if someone is suffering from GERD, so gastroesophageal reflux disease, you'll have the acid from the stomach coming up into your esophagus. And you might have heard people, when you have heartburn or something, and sometimes it can be mistaken for a heart attack if the pain's that severe. So you have the acid coming up into the esophagus. So you would expect pain around the chest and around the esophagus. But for it to come all the way up to the throat is much less likely. Again, it can happen, but that's not what you should be thinking of when you hear a patient with this kind of presentation. And then finally, oral candidiasis due to steroids. Yes, so especially women, unfortunately, might be aware of this. So oral candidiasis, which is thrush, that is a common side effect of corticosteroid use. It creates an environment that is easier for the fungus to grow and develop, so for thrush. But if a patient has thrush in the mouth, you're going to be looking more for white patches in the mouth as opposed to a sore throat. So this patient doesn't present with any white patches as far as we're aware, just a sore throat. So that's not what we're going to be thinking of. So that gives us our correct answer of a granulocytosis. In the management of Crohn's disease, budesonide has limited systemic effects compared to oral prednisolone. This is because butenocide is which one of the following? So is it that it is an ACTH or adrenocorticotropic hormone receptor agonist? Is it that it is given as a transdermal cream? Is it the active molecule of prednisolone? Is it the precursor or prodrug for prednisolone? Or is it that it undergoes first-pass metabolism? So let's start from the top. Is it an ACTH receptor agonist? Well, no. Butenocide is a glucocorticoid receptor. So as the name implies, you would expect it to work on a glucocorticoid receptor, not on an adrenocorticotropic receptor. It is given as a transdermal cream. So butenocide is available in various forms, but it's very rarely given as a transdermal cream. It's usually an oral capsule you'll be taking. Sometimes you can have enemas, so not fun, but as particularly in the treatment of Crohn's disease, sometimes you'll get an enema as opposed to taking it orally, but it's not something that's usually given as a cream. So is it the active molecule of prednisolone? No, that it's a different glucocorticoid steroid with distinct chemical structure, completely distinct pharmacological properties. I mean, if it was the active molecule of prednisolone, if anything, you would associate or assume that butenocide would have a greater effect than oral prednisolone, not a lesser effect, since it's basically just saying that it's the more concentrated form. So that wouldn't make any sense. And then is it the precursor or prodrug for prednisolone? And no, again, they are completely different steroids. Butenocide is an active glucocorticoid steroid itself. It's not just a precursor for prednisolone. So that gives us the correct answer of undergoes significant first-pass metabolism. So when someone takes a drug, especially when you take it orally, it's absorbed from the gastrointestinal tract into the bloodstream, and then it's carried to the liver via the portal vein. So in the liver, the drug then undergoes chemical changes, and this is usually through enzymatic reactions before it then reaches the systemic circulation, so when it starts to actually get into your vascular system. And this whole process is known as first pass metabolism. So during first pass metabolism, drugs can be metabolized into inactive metabolites, which can reduce the amount of active drug that reaches this systemic circulation. As a result, the bioavailability of the drug may be reduced. So the bioavailability of a drug refers to the percentage of the administered dose of a drug that reaches this vascular system, that reaches the circulation in its unchanged form, and so is therefore able to exert its pharmacological effect. So it's basically just a way of saying, if we give you a drug and you take it and it's then like gone through your body, gone through the liver, all metabolized, how much of the drug did we initially give you actually get into the bloodstream and is able to produce its desired effect? Now, it's important to note that just because something undergoes first pass metabolism does not necessarily mean that it's not a good drug for what you're trying to do. In fact, sometimes it's actually beneficial. For instance, butyronicide has limited systemic effects compared to oral prednisolone because it undergoes significant first pass metabolism. And as a result of this, it has less systemic side effects than prednisolone. Drugs with higher first pass metabolism usually have a more localized action. They have a reduced risk of drug interactions, reduced risk of toxicity, as well as reduced side effects. So it's just an important point to get across, because I know, especially when I was first learning it, I assumed if something underwent significant first pass metabolism that it was just not a good drug, and that's not the case. It completely depends on the situation and the context, but there might be certain situations where a drug with a high first pass metabolism is actually the one you want over something which doesn't lose its bioavailability as much. Now, it's important to note that just because something undergoes first pass metabolism does not necessarily mean that it's not a good drug for what you're trying to do. In fact, sometimes it's actually beneficial. For instance, butyronicide has limited systemic effects compared to oral prednisolone because it undergoes significant first pass metabolism. And as a result of this, it has less systemic side effects than prednisolone. Drugs with higher first pass metabolism usually have a more localized action. They have a reduced risk of drug interactions, reduced risk of toxicity, as well as reduced side effects. So it's just an important point to get across, because I know, especially when I was first learning it, I assumed if something underwent significant first pass metabolism that it was just not a good drug, and that's not the case. It completely depends on the situation and the context, but there might be certain situations where a drug with a high first pass metabolism is actually the one you want over something which doesn't lose its bioavailability as much. Question 58. In the management of resistant Crohn's disease, which one of the following is not an appropriate course of action? Is it bowel rest with parenteral feeding, treatment with a monoclonal antibody to TNF-alpha, so infliximab, treatment with azathioprine, treatment with oral prednisolone, or treatment with tricyclic antidepressants? Okay, so parenteral feeding is a way to feed a patient which bypasses the gastrointestinal tract. So, sometimes you see people when they're in hospital for a long time and they'll have something inserted intravenously and that supplies them with nutrients. Especially if you've seen any shows where someone's in a coma or something else, obviously we need to find a way to get them the nutrients they need. This is a process we use when a person can't receive feeding or fluids by mouth, or in the case of someone with Crohn's disease, because it's quite severe, especially in resistant Crohn's, they're not able to absorb the food that they need. So Having bowel rest with parenteral feeding is something that is used during acute flares of Crohn's disease, and that helps to rest the bowels and also to reduce inflammation. So that will help reduce the symptoms. So it's not that one. Treatment with monoclonal antibody, TNF alpha. So this is something that we use when the traditional methods, the first line methods, don't work. So usually you'll use something to try and lower the immune system, so steroids, stuff like that, to help with the inflammation process. If that doesn't work, then TNF alpha inhibitors such as infliximab are actually quite commonly used in the management of Crohn's disease. In fact, one of my best friends, probably my best friend actually. I don't really rank my friends in terms of hierarchy, but one of my best friends has been suffering from Crohn's disease for like the past year, and he has to have one of the injections. I think for him, he takes it every month, and that's something to help manage it because the other medication hasn't really worked for him. So it's not fun. You have to stab it in you, get it into your system, but if other treatment methods don't work, then monoclonal antibodies is something that we will go towards. Treatment with azathioprine, and I'm probably butchered the pronunciation of that. Azathioprine is an immunosuppressant medication, and well, Crohn's disease is a type of disease caused by the body attacking itself. It's an inflammatory disease. So an immunosuppressive medication is absolutely the kind of stuff that we would use, especially if it's not responsive to other treatments. So it's not that. And then we have treatment with oral prednisolone. So prednisolone is a corticosteroid, and that's what is quite commonly used to induce remission in Crohn's disease, and particularly when you have these acute flares. It's not usually suitable for long-term maintenance therapy due to their side effects, but it would be an appropriate course of action in some situations if Crohn's disease is quite resistant. So the correct answer is the obvious one. Treatment with tricyclic antidepressants. I mean, the clue's kind of in the name. I think sometimes this can catch people out because sometimes the medication that we use for different problems don't seem to make a huge amount of logical sense. Like sometimes we'll give someone a beta blocker to deal with migraines. So beta blockers are something that slow down the heart, and that's something that we will often give for cardiac issues. But in addition to cardiac issues, beta blockers you can sometimes give for anxiety, because one of the symptoms if you have your heart rate beating too much, so we'll give it for that. Sometimes we'll give it for headaches. So it can catch some people out, but in this particular situation, it's the obvious one. We do not treat Crohn's disease with tricyclic antidepressants. Question 59. It is decided to add methotrexate to a patient with resistant Crohn's disease. When prescribing methotrexate, which one of the following is an important consideration? So is it that a loading dose is required? Is it that calcium supplementation is required? It can lead to folate toxicity. It may adversely affect blood glucose control, or it should be prescribed as a weekly dose. Okay, so what is methotrexate? So methotrexate is a chemotherapy agent, and it's also used as an immune system suppressant. So it's used to treat cancer, and it's used to treat autoimmune diseases such as Crohn's disease. You have to be careful with it because it has a lot of side effects, including hepatotoxicity, like stomatitis, stuff like that. And folic acid can reduce some of the side effects of methotrexate. So quite often when someone is given methotrexate, you will have folic acid given alongside it to help alleviate some of those side effects. So let's go through some of the options. So a loading dose is required. This is incorrect. So methotrexate is usually initiated without a loading dose. So a loading dose is basically just saying that the first time you give the medication to a patient, you will give them a higher than usual dose so that you can achieve a rapid therapeutic effect. Calcium supplementation is required? No. So methotrexate is not something that we typically associate with hypocalcemia. So giving additional calcium supplementation is not something that we would have. It can lead to folate toxicity. This is incorrect, and I know a lot of people got caught out by this. So methotrexate can include toxic elements, so it can lead to hepatotoxicity. However, it actually reduces folic acid, so you'll give folic acid alongside it. So it's important to remember that just because something causes toxicity of some description, if you have a question that's saying a specific type of toxicity, for instance folate toxicity, it's not always going to be that as the answer. There are different types of toxicity, and in the case of methotrexate, we will give supplementation because it lowers folate levels, doesn't increase them. It may adversely affect blood glucose. No, as far as we're aware, and it's not a common risk factor of it. So methotrexate is not known to adversely affect blood glucose content. So that gives us the correct answer, that it should be prescribed weekly. This helps to minimize some of the side effects, and it helps to optimize the therapeutic benefits of methotrexate. So it's something that is only prescribed weekly, and a way you can try and help remember it is that it's a chemotherapy drug. So if it's a chemotherapy drug, it's something that can cause quite a lot of damage to your system. So you don't want to be giving it constantly. And unfortunately, if ever you have known someone who has undergone chemotherapy, you'll know that there is quite a gap between different chemotherapy doses. You know, we're not just plugging them full of chemotherapy all the time, because it can cause a lot of damage to the body. So it's something that we have to monitor quite closely. All these kinds of drugs, especially immunosuppressants, so we're doing it to manage some kind of disease, but we have to be careful because we are causing damage. Like chemotherapy, the idea is we want to take out the cancer cells, but it's going to be causing damage to the entire body. We're just hoping that it affects the cancer cells more. And if it's going to be causing a suppression to the immune system, obviously we give you too much, that's going to potentially kill you, because now you don't have any immune system to fight off infection. So something that should only be prescribed weekly, and that's how I personally remember it. Chemotherapy agents we're not going to be given daily. Question 60. The above patient taking methotrexate had self-medicated with ibuprofen, and his doctor suspected the patient was suffering from methotrexate toxicity. Which one of the following should now be measured or determined? Is it a full blood count? Is it a liver function test or an LFT, plasma levels of ibuprofen, potassium levels, or visual acuity? So methotrexate and ibuprofen are both medications that can cause certain gastrointestinal side effects. So taking them both together can increase gastrointestinal ulcers, gastrointestinal bleeding, kidney damage, but also most importantly, it can actually decrease methotrexate clearance because of the interaction that undergoes. So if you have decreased methotrexate clearance, that can lead to increased levels of methotrexate and an increased risk of methotrexate toxicity. And as we talked about earlier, with methotrexate being both an immunosuppressant and a chemotherapic agent, that can cause a lot of problems to the body. So if you start to suffer from methotrexate toxicity, it does a lot of things. As you can see from this diagram, it affects a lot of different organs. So it suppresses the bone marrow's ability to produce blood cells, so that can lead to anemia, which is where you have a decreased level of red blood cells. It can lead to thrombocytopenia, so decreased platelet count, so you're much more prone to bruising and bleeding. It leads to leukopenia, so decreased white blood cell count. And if we kind of go through the different systems we have here, it can cause liver damage, so liver toxicity. So you can get inflammation of the liver, so hepatitis, fibrosis of the liver, so scarring of the liver tissue. It also increases the levels of liver enzymes in the blood, so that's elevated liver enzymes. In addition to that, it can cause pulmonary toxicity, so it starts to affect your lungs. So it can cause pneumonitis, so inflammation of lung tissue. It can cause scarring of the lung tissue, so different types of interstitial lung disease. Renal toxicity, a lot of gastrointestinal toxicity. It can cause a lot of problems. So methotrexate toxicity is something that we really need to watch out for. So knowing that, what one of these would be the most important thing to look into? Well, which one of these is going to give us the full picture? So if you have put full red blood count, you would be correct. And I know this one can kind of catch people off because a lot of people, they assume that there's going to be some kind of toxicity. We probably want an LFT. You know, if the liver is the one that is undergoing metabolism of the drug, that's something you want to check. And yes, liver function tests can be useful in monitoring methotrexate toxicity, especially if the patient is suffering from hepatic toxicity. However, if the patient does have this kind of toxicity, it's affecting more than just the liver. It's affecting the whole body. And so we want to find out very quickly what's going on. So in particular, the fact that it can suppress bone marrow suppression and can cause a lot of blood problems, the first thing we want to be doing is getting a full blood count to see what's going on. You know, are there decreased levels of blood cells, white blood cells, platelets, all that kind of thing. And as a rule of thumb, when you're in the medical world, a full blood count is usually one of the first things we'll do because it's pretty easy to obtain and it gives us a pretty good idea of all of the different kind of problems that are going on. So I won't go so far as to say it's first line investigation because there's a lot of nuances involved in medicine, so it's not always first line. But quite often that's the first thing you want to look at. Okay, what's the full blood count? What's going on? And if we're struggling at that point to figure out what the problem is, then we will go and look into something else. You know, start doing other tests that are a little bit more specific on certain diseases if we have a little bit of an idea of what area to look at. So plasma levels of ibuprofen, yeah, that can be important to determine if there is ibuprofen toxicity, but in this particular case we have no reason to suspect that the patient does have ibuprofen toxicity. It's more that it has caused this side effect and is now leading to methotrexate toxicity. So we don't need to be measuring that directly. That's not the biggest concern for us. Potassium levels, so methotrexate causes a wide range of symptoms, but potassium level abnormalities, that's not something that we typically associate with it. And then final, visual acuity, this is not something that is directly related to methotrexate toxicity. It could be a secondary characteristic if there's some kind of underlying health condition with the patient, but it's not what's of immediate concern. So in this particular case, the first thing we want to do is get a full blood count. Alright, unfortunately the next question is a different group of them, so we'll save that for next time. I hope this has been helpful. Please let me know if the change in style is useful or less useful, if I should go back to taking my time a little bit more instead of having these jump cuts. I hope that by doing the jump cuts I can cut out quite so much of the faffing that I do, especially when my brain doesn't quite work. But if you prefer the other style, let me know and I'll go back to it. And as always, if you have any questions or if there's anything that I wasn't explaining clearly enough, please leave a comment and I will try to get back to you as soon as I can. All the best. Take care for now.